The COVID-19 pandemic had an impact across all CRFs in the country for both staff and portfolio delivery. All CRFs have shown great adaptability and flexibility in response to the pandemic, and all have contributed to the national efforts. The COVID-19 pandemic has posed a challenge to our business as usual in terms of having to pause non-public health England studies during the first lockdown, adapting to a new COVID environment on site, and managing restarting studies alongside urgent public health vaccine trials. Inevitably, for some CRFs, non-COVID specialty activity has been reduced, with setup of new studies also affected, and at times a significant proportion of the workforce not able to work on site because of the COVID risk. In most cases, CRFs have had to stand down existing portfolio studies to enable deployment of staff to either clinical services or UPH studies. As more research developed, such as vaccine trials, antibody studies, etc., more staff were appropriately returned to clinical research activity to cover UPH studies. By September, majority of CRFs reported that only between 0 to 20% of staff were still redeployed clinically. Most CRFs, including Oxford Health Cognitive Health CRF, established prioritization processes in line with NIHR Restart Framework to decide capacity and portfolio delivery. Urgent Public Health England studies were given priority for discussion so that decisions to progress were made rapidly. By the end of March 2021, around 50 studies, which is about 1% of the total portfolio, were reported as suspended due to the impact of COVID-19. This is lower than the 369 studies reported in 2019-2020. The total number of suspended studies, 180, was still considerably higher than 2 years ago pre-pandemic, when only 38 studies were reported as suspended. The CRFs supported 101 UPH studies, 32 of them being vaccine trials. First participants globally for the Janssen and Ensemble 2 and Novavax vaccine studies were recruited in the UK, respectively. An early example of CRF's adaptability and commitment to clinical research during the pandemic was delivering the Oxford Astrazeneca vaccine trial. This started as a phase 1 developed by the Oxford Vaccine Group and was delivered throughout its further phases by multiple CRFs across the country: Southampton, Imperial College, Oxford, etc. Southampton CRF supported all CRM regions and devolved nation setup of large-scale vaccine trial delivery by sharing project management, workforce, and logistic planning processes. The UK was also the first country in the world to undertake and deliver the phase 3 trial for the Novavax vaccine. The NIHR-supported study achieved its recruitment target in just 2 months, with 15,203 volunteers from across the country recruited in record time. A number of CRFs combined forces with other NIHR infrastructures to help deliver this trial. For instance, through a huge team effort, the NIHR Oxford Cognitive Health CRF screened their first participant 4 days after signing the Novavax contract, with 463 participants recruited over 1 month and 2,657 visits facilitated to date. The Novavax study is now the largest double-blind, placebo-controlled COVID-19 vaccine trial to be undertaken in the UK. Staff and services adapted rapidly by opening new COVID-19 trials in record speed, staff working weekends and bank holidays, and CRFs opened at extended capacity when required to get urgent trials open in record speed. These include early phase platform trials such as Agile, Tactic, Accord 2, Define, and Catalyst, all prioritized to find urgent treatment for patients. A common theme across the CRFs in response to the pandemic has been developing new collaboration, but also strengthening existing ones with local R&D departments, other infrastructures like local CRNs, BRCs, etc. And it has been a challenging period, but upon reflection, some of the most commonly used words used by CRFs to describe it have been adaptability, collaboration, inspiring, and rewarding, showing the importance of these collaborations moving forward and the CRF's eagerness to develop their potential. The CRF community has been commended for the efforts that have been taken at an individual site level and across the network to support the response to the pandemic, both at the front line and in initiating and supporting research efforts. It is our community and infrastructure that has been crucial in responding swiftly to the pandemic and undertaking the setup and delivery of the national platform studies and vaccine development work.
Some of the words used to describe the CRF's response to the COVID pandemic include adaptable, flexible and versatile. CRF staff have been redeployed to non-research roles, supported clinical services and taken on extra duties or new roles within their CRF, all whilst dealing with their own personal COVID-related challenges. CRF staff have regularly demonstrated their can-do approach, rising to new challenges in a rapidly changing environment. To relieve pressure on clinical services, Edinburgh CRF set up a haemo-oncology service, delivering 1,400 treatments over a 12-week period. Great Ormond Street CRF were instrumental in the training and delivery of the staff COVID vaccination programme, and Northern Ireland CRF established a regional vaccine delivery team. The education lead at Cambridge CRF was redeployed at the start of the pandemic and has trained 850 staff in the management of respiratory patients. And when working on COVID studies on the ward, Leicester CRF helped ward staff by taking observations, making beds and trying to minimise their impact on the ward's workload. Throughout the pandemic, the urgency of COVID research has led to CRFs implementing new systems, creating new roles and adapting existing roles to help expedite study setup and delivery. The Deputy Manager at Birmingham Adult CRF became a trial coordinator for COVID testing studies, writing protocols and preparing IRAS submissions. This identified a gap, which has led to the CRF creating a new Senior Clinical Trials Coordinator post. It was all hands on deck at Coventry and Warwickshire CRF, I myself performing data entry for our COVID vaccine study and supporting our pharmacy department to coordinate delivery of trial medication to participants' homes, something we hadn't done before. Delivering COVID research studies safely and efficiently required many CRFs to think outside the box, and CRF staff were asked to leave their purpose-built facilities to deliver COVID research in unfamiliar settings. When running a study involving the children of healthcare workers, Glasgow CRF ensured social distancing by utilising the large on-site car park and walkie-talkies. CRFs were also seen using sports halls to deliver the vaccine studies, including Southampton and Leeds CRF, which allowed rapid recruitment whilst maintaining social distancing. The safety of CRF visitors was paramount, and keeping research participants with confirmed or suspected COVID separate from other visitors was a key concern for many. Some CRFs utilised facilities already in place at their host organisations. At Coventry and Warwickshire CRF, we recruited symptomatic healthcare staff and members of their household in our Trust's COVID testing hub, which was set up at the start of the pandemic. Imperial CRF created the ICRF Annex in a space at Hammersmith Hospital. The Annex has 4 fully equipped rooms to see symptomatic participants. Other CRFs repurposed existing research space. Birmingham CRF used their house research bus. Locating the bus on the University of Birmingham car park meant participants with confirmed or suspected COVID could park right outside and attend their appointment whilst avoiding contact with other visitors. Some CRFs created completely new facilities. Cambridge CRF installed a COVID satellite and King's CRF installed their very own swabbing pod. These investments have provided safe, separate spaces where research participants with confirmed or suspected COVID can be seen without coming into contact with other site visitors. There's also been other investment in CRF infrastructure during the pandemic. In light of the large-scale vaccine work and restart of other studies, Imperial CRF set up a new research hub at Charing Cross Hospital, which has provided an additional 9 rooms for delivering vaccine and other studies. In partnership with the University of Surrey and the NIHR Kent, Surrey and Sussex CRN, Royal Surrey NHS Foundation Trust built a pop-up CRF by converting the ground floor of an office block, creating additional capacity to deliver urgent public health studies. If the pandemic has shown us anything, it's how CRFs are able to adapt, undertaking new duties and roles, changing systems and processes, moving outside of the immediate CRF infrastructure and investing in new facilities to ensure research is conducted safely and efficiently. I've only highlighted a small number of examples today, and there are many, many more out there. The response from CRFs during such unprecedented and challenging times has been truly inspiring.
All of the efforts described so far have had amazing results, and I'd like to reflect on some of these highlights with you. I have a note of caution though. Despite best efforts, we don't have data from all CRFs across the devolved nations. However, we do have some Scottish figures to share. As staff were redeployed from CRFs, it was assumed that the paused portfolios of trials led to a paused research service, but this is not the case. All CRFs worked within their host NHS trusts to meet their local priorities, and while some CRFs maintained their trials portfolio, others paused theirs in line with NIHR guidance and their R&D response, and this is reflected in some key metrics that I would like to share with you. Feedback from our NIHR report shows that in the year 2020 to 2021, the NIHR CRFs have collectively recruited 123,108 participants to trials, and this is an amazing increase of 62% on the previous year, resulting in an increase of 64% in participant visits. We know that additional information from other CRFs will only take these numbers higher. CRFs have contributed to a national research endeavour that includes delivery of 1,151,489 recruits to 101 urgent public health studies and 46,748 recruits to 32 vaccine studies. In Scotland, over 36,000 people have signed up to the NHS COVID19 vaccine research registry, and over 79,900 participants have taken part in 168 COVID studies throughout Scotland, and that's as of October 2021. Additionally, a YouGov survey in May found that 89% of Scottish adults think that health research played a fairly or very important role in the pandemic. In many cases, this activity has been in addition to CRF staff being redeployed to frontline clinical services. By August 2020, CRFs reported more of a balance, with a repurposed workforce supporting vaccine, COVID and non-COVID trials, some of which did not pause. From our NIHR data, 54% of NIHR CRFs supported vaccine trials at this time, while 77% supported urgent public health studies, including patient treatment trials. At the same time, whilst leading a great deal of this work, CRF staff have responded to urgent calls for information gathering. Between April and September 2020, these included 35 requests for activity and staffing information through the UKCRF network to help inform the NIHR response to government, reporting examples of CRF added value to the pandemic response for use by the NIHR, monthly staffing information for central commissioning facility use, responding to information requests from UK Research and Development Group, daily activity reporting to our own trusts, and not forgetting compiling the CRF annual report. I'd just like to share some key CRF highlights with you. These include CRF-led projects joining R&D infrastructure and teams together to deliver large-scale COVID-19 vaccine research portfolios, particularly highlighted by Edinburgh, Northern Ireland, UCLH, Gosh Paediatrics and Oxford Health. CRFs have also joined forces with clinical research networks to deliver urgent public health studies, including multidisciplinary teams such as laboratory staff and data management teams, particularly highlighted across Wessex, West Midlands and London. A large number of CRFs are also collaborating to deliver 14 NIHR COVID-19 bioresource recruitment and Stage 2 studies led by Cambridge. And Leeds PPIEP Group co-produced a video, Be Part of COVID-19 Vaccine Research, adopted by the NIHR. As well as these, there have also been a number of collaborations with other networks, highlighting common concerns and how to overcome them, such as restarting research portfolios, monitoring both remotely and safely on site, and operational practicalities, mainly due to reduced clinical services. CRF managers have contributed to new national guidelines such as the ECMC Remote Monitoring Guide and access to electronic health records by sponsor representatives in clinical trials, which was jointly developed by the NHRA, the MHRA and the Information Commissioner's Office on behalf of the UK. Finally, I've attended meetings and words such as exhausted, emotional and perseverance have dominated our conversations. However, the one that I've used the most is proud. Proud for the united efforts across CRFs, proud of the support we've given each other, both personally and professionally, and proud of what we've achieved for our patients and global health. Thank you.
Thank you very much, Claudia, Tracy and Joe. Fantastic videos. Totally all of us out of our comfort zone, but it's been great. So we have a few minutes now for the Q&A session, and we've got a question to start us off with. And that is, I wonder if you would like to tell us of a particular change that your CRF has made as a result of COVID that you've kept going or that you intend to keep going. Let's start with Claudia.
Sure. Hi, everybody. So I think all of the CRF made a lot of changes to respond to the pandemic. For our CRF, Oxford Cognitive Health CRF, I think one of the main ones I'd like to mention is ability that we've developed, because to be able to run UPH studies in a really short amount of time with a lot of people and also continue to run at least some of our regular activity, we had to put in place quite a few practical changes. For example, extended capacity, extended hours, our staff working shifts, being open Monday to Sunday, long days. And that's something that was actually very useful and we intend to continue. So even though our core opening hours remain Friday 9 to 5, we now have the flexibility to open over the weekend and accommodate evening visits for any stuff that we run. And we're incorporating overnight visits too now. So a lot of the learning was practical too.
So it's a massive change then for your CRF. Tracy,
Yeah.
How about you?
Hi everyone. Yeah, I think one of the things that we're taking away with us is the number of new relationships we've managed to create with, especially with our new respiratory and infectious disease researchers. So that's something we're definitely going to continue with, and also the relationships we've built up at ward level, the way that we've been able to raise awareness of both research in general, but also the CRF at that level. So yeah, I think that's what we will continue to try and do.
Great. And I think that's quite a common theme across quite a few CRFs, that actually the pandemic has raised the profile of CRFs and the type of skills we have and what we can offer in our host trusts. Joe, last but not least.
Thanks, Caroline. Yeah, I echo all of that. And certainly for us at our trust, our R&D now stretches across 4 acute hospitals. And during the pandemic, as everyone said, you know, that wider working has led to new relationships, and we are absolutely carrying that forward. We're working as one whole R&D across all those sites, and our CRF is reaching much further to build relationships and run some bigger studies in a collaborative way across all those sites. Thanks.
So Joe, I assume you've got avatars in all the other centres then?
Absolutely.
Okay, great. Now we've got another question that's come in, and that is, what is the key learning that we can take from the pandemic?
Well, I'd like to jump in there and just talk about the success of the registries for us. So our excellent recruitment, and I think everyone found the same, that having the registry to work from and being able to contact people that had already consented to be contacted in quite a fast way in our region really helped us achieve our recruitment targets. I think that, coupled with the non-medic consent receiving, has really changed the way we sort of view all our activity across the vaccine trials, and we'd look forward to taking that forward further in other areas. Okay,
thank you. When you say non-medic consenting, is that by a particular individual in your CRF, a sort of specialist nurse or something, or across the board?
It was across the board, Caroline. So I think everyone found there were so many roles that needed to take place concurrently to enable the vaccine visits to take place, such as live monitoring, receiving consents, as well as then enabling the sign off of eligibility criteria, that we pulled some really skilled people together, and people found their niche as well. So it was an opportunity for staff to skill up as well, which was fab.
Great workforce development opportunities then.
Yeah, absolutely.
Right, I'm just reading another question here. It says, will many of the changes introduced radically change working practices moving forward? For example, virtual clinics, expedited setup, expanded data capture and reporting. That's a lot of questions all in one sentence.
I'm happy and just give a bit of insight on the first couple, less sure on the data capture and reporting, but when it comes to things like virtual clinics and expedited setup, I'm sure this is echoed across the network, but everything that we've put in place and learned throughout the pandemic can be translated into change in practice. So at least for Oxford CRF, it's really made us hone as in and for that it taught us that we can open a trial quickly and safely. It doesn't have to be one or the other due to these processes and people working together. So I think between the collaboration, clear processes in place, and the possibility of expanded communication due to online, making it easier and quicker for meetings with people across the country, it's gonna, well, at least for us, it's definitely reduced setup times, even for non-UPH studies. And we are having a lot more virtual clinics and a lot more aspects of studies are incorporated into remote visits compared to face-to-face, which enables us to run more, if that makes sense.
Great. Any, Tracy, Joe, do you want to add to that, or I can come up with the next question?
I think Claudia covered quite a lot of it, but I think the expectations will have changed definitely from, that people know that we can do this now. And I mentioned in my presentation, we can think outside the box with virtual clinics and, expediting setup. But like Claudia said, we can still do things safely but efficiently.
Okay, so we've got another question here. What tips would you give to facilitate and continue the collaboration between CRFs and the ward staff?
So I think, Caroline, from my point of view, it's always going to be communication, isn't it? It's having that presence, which is something that COVID gave us the opportunity to do, was to go onto the wards, to meet people, to build these relationships. And I do think that that's something that we need to continue. I know at our CRF, we are looking at putting something on in the new year as kind of, not necessarily an introduction, but for hopefully, if we find out we get funding for the next 5 years, this is what our plans are. And that will be for research staff, but also for the wider trust as well. So, yeah, I definitely think communication, making people remember who you are.
Great. Joe, anything?
Yeah, and we've actually started conversations with our exec team this week, looking to see if we can build a framework whereby not just ward staff, but also clinical support services can actually opt in and use part of their substantive post timing to work within the RD&I teams. Obviously, we need to make sure that that's right for both their base post, but also for RD&I. But there's a lot of enthusiasm out there after seeing, what research actually involves and the amount of patient contact you have during research. It's not all paper based. So really positive in our trust across the board.
Okay, so before I consider the next question, I'm just going to come back to the CRF manager group, which I think has been key to supporting CRF staff throughout COVID. And it's really come together well and helped to support people on the ground in their own CRFs, but also to provide a vehicle for providing the reports, Joe, that you spoke of. Do you see that forum will continue in that same format and meet that frequently?
Absolutely. I think, and I know Claudia and Tracy both have found benefits through the regular meetings. And from my point of view, having spent a number of years organising a yearly meeting. Actually, the monthly meetings are easier to attend, but also much more collaborative. We share the time between each other to showcase our CRFs. So yes, it achieved a lot during the pandemic, but going forwards, the networking is so much closer, and we're looking to encourage. I know there's coffee mornings now started with virtual meetings for other staff members, but we are encouraging it and across other networks. So we attend the ECMC networking groups, and we're looking to see how we can facilitate the ongoing meetings with other infrastructures such as the CRN, which was a major factor in how we worked in Birmingham through the pandemic.
Yeah. And Claudia, you came to your CRF very close to the start of COVID. So how did you find this forum?
I did want to jump in and echo what Joe said, because I think prior to the pandemic, there was a lot of support from the network, but it was a bit less tangible because we weren't seeing each other. It was more theoretical, if you will. So I feel throughout the pandemic, it made us feel a lot more integrated. It helped us because despite working towards a very common goal, all the CRFs are quite different from each other. And we feel that in Oxford because we're a cognitive health CRF, so even more so. And having these regular meetings and the support from the network and from each other, it's really made us feel a lot more empowered. It's been more action driven. So I feel like it's been less abstract, less theoretical, and more, okay, this is how we do it at our CRF. Would it work at yours? So sharing that knowledge, sharing that support, I think created a real connection between the CRFs. I'd be incredibly keen for that to continue. And I found it particularly useful because I started as CRF manager just prior to the pandemic. So I feel like it was really good timing for me because I received all of this support from the other CRF managers.
That's great. Okay, we've got probably time for one more question before I have to talk about the next bit. Right, so questions come in about how has working extra hours been funded and how did the staff feel about that? Joe, you've said you'll give us your Birmingham view on that, and then Claudia after.
Yeah, so in Birmingham, the way we normally work with extra hours is where we have funding, we then maximise that time. So if we have studies that are academic and there isn't specific funding for the extra opening hours or any form of bank work, then we use our whole pot of money to make sure that we make the best of sort of the staff working those hours. So it may be funded for one specific study, but actually everybody's time is used as effective as it can be. So we cover those costs. I know some trusts had sort of combined working, and CRFs were part of their loss of income during the pandemic. I think as a network, we probably need to take those talks forward and make sure that we have consistency across the network so we can maximise everybody's potential.
Great. And Claudia, do you want to add to that?
Yeah, we did something similar in Oxford, but the thing that I'd like to add is that we tried to be as flexible as we could in terms of use of time for staff as well. So people worked hours because they chose to. Other people took time back. For example, they worked in the weekend, had time off in the week. It was really important for us because staff showed how incredibly devoted they are. And I really want to, thank them for that, and went above and beyond. We were really mindful of potential burnout, which I think it was difficult to prevent. But we all tried to be really flexible. So yes, some staff did overtime, other staff took time back. And they felt, I don't want to speak for them, but I think they did feel heard throughout, despite working very, very, very hard. They felt it was quite rewarding.
Okay, thank you. Right, Tracy, we can just squeeze you in. I think we've got 2 minutes before we have to go to networking that I need to introduce. So over to you.
That's fine. So like Joe said, we were one of the CRFs that our COVID team merged with the wider R&D. So the hours were kind of covered between the two groups. So as Claudia was just saying, they would have staff off during the week, and then they would work weekends. We had people working Christmas Day last year, but actually I never heard anyone moan about it. They just, like Claudia said, they just kind of did it and got on with it, which for people that are routinely used to working kind of office hours almost a lot of the time with the odd weekend, to not know when this will finish as well, I was just, they were amazing with it, really. So just to say thank you to everyone.
That's a great note to end on. Thank you to you three. You've been terrific.